This is a video about my first week in surgery. You have a diabetic patient. You want to do a neuropathy to assess the patient for neuropathy and do a vascular assessment for this patient. What are the things you should do? For neuropathic index, you are going to assess if the patient has any loss of vibration. This is called the vibration perception index. Okay, and you should look for pressure sensation and pain and temperature by the monofilament test and ankle reflex. So 4 things for neuropathic index. We have the vibration sensation, pressure sensation, pain and temperature, and last but not least, knee reflex. The vascular assessment of a patient with diabetes will include 4 things for the artery and 1 for the vein. We have the ankle brachial index, Berger test, temperature of the limb, and distance of claudication. And for the vein, we have the venous filling time. For the ankle brachial index, you are going to measure the blood pressure in the lower limb divided by the blood pressure in the upper limb. Of course, it's systolic, and the ratio normally is from 0.9 up to 1. If it's less than 0.3, it indicates severe critical ischemia. Then we are going to do a Berger test, in which you elevate, the patient is lying supine, you elevate the leg up and look for pallor. The third thing is the temperature. You palpate for temperature difference in the limb. The fourth thing is distance of claudication. Claudication might be arterial, might be venous, or might be even due to musculoskeletal problems, especially spinal injury. Arterial claudication, usually it's related to walking. Okay, when the patient walk a fixed distance, or distance might be decreasing throughout time, but it's usually fixed. Okay, and it decreases by rest. The pain decreases by rest. But in venous claudication, the pain will increase by standing and decrease by walking, and decrease also by elevating the limbs up. Okay. Then we have the venous filling time. The venous filling time, in which the patient will stand and you stand up from supine position. The patient will stand and you look for how much it takes for the venous superficial venous system to fill up. Because as you know, the venous system is affected by neuropathy. If you have neuropathy, the venous system also will be affected. So we have 2 things. What are the signs of healing ulcer? Healing ulcer. The ulcer will heal by, first thing, the signs of healing ulcer include granulation tissue, the edges of the ulcer become white due to epithelialization, and the sloped edge ulcer. What's pneumothorax? Pneumothorax is air in the pleural cavity. Air in the pleural cavity. This air will lead to hemodynamic instability, especially if it's a tension pneumothorax, and lead to respiratory failure. What are the causes? Might be spontaneous or primary pneumothorax due to ruptured emphysematous bully in tall, young male patient, or it might be secondary to asthma, COPD, tuberculosis, pneumonia. Diabetic foot. What are the grades of diabetic foot? By Wagner's classification, grade 0 includes there is no ulcer, grade 1 superficial ulcer, grade 2 there is a deep ulcer, but there is no involvement with infection of the underlying tissue. At grade 3, deep ulcer with osteomyelitis, abscess, or septic arthritis. Grade 4, it's a localized gangrene. Grade 5, it's a generalized gangrene. Now, from the history, the onset of the pain is very important. If the patient has a pain which has the onset of the pain is very, very fast. The onset, it's a very fast pain, okay, and developing over minutes, okay, and reach the maximum intensity over minutes. This is usually perforated viscous or aortic dissecting aneurysm. Of course, we are talking about GI problems. If the pain develops over 2 hours, this might be a colicky pain or acute obstruction. But if the pain develops over 6 hours or more, this is usually an inflammatory pain. It might be just an appendicitis. This is the onset of the pain. What about the site of the pain? If the pain is the side of the pain will differ. If it's a somatic pain, usually the pain will be well localized and related to its anatomical position of the organ, okay, and it might be stimulated by anything: chemical, mechanical, physical, ischemia, or dilatation. But the visceral pain is usually vague and it's not related to the anatomical relation, has no relation to its anatomical position of the viscera which was involved, okay, and it's usually only stimulated by distension or ischemia. The pain in the GIT, so how its embryonic origin? We said that the visceral pain is vague and it's not related to its anatomical origin. It's related to its embryological origin, specifically to its blood supply. For example, the foregut is supplied by celiac artery, so the pain is usually is epigastric. The midgut, the pain is usually is in the paraumbilical region because it's supplied by the superior mesenteric artery. The midgut is supplied by the inferior mesenteric artery, and the pain usually in the lower part of the abdomen. But note that the lower third of the canal has a somatic pain and not a visceral pain. Types of pain, there's a lot of types of pain: the colicky, the burning, the constricting as in ischemia, the tearing pain, okay, but there's something important that you should know, that the colicky pain of cholecystitis, of ureter colic, this pain is called colicky because it has three prerequisites. Those three prerequisites include: 1, a hollow viscous; 2, a hollow viscous which has a peristaltic movement; 3, there should be an obstruction to this peristalsis. So hollow viscous, peristalsis, and obstruction. What are the aggravating factors? Aggravating factor might be physical, might be humoral. Physical aggravating factor, of course, if you have an ulcer, okay, and when you eat you have pain, okay, or you have a lesion in the stomach. But if you have a cholecystitis, a fatty dyspepsia, okay, acute cholecystitis, when you eat fatty food you will have the pain, but this pain will start only 1 to 2 hours later on. And the same in the meantime, after the patient vomits the gastric contents, the pain only relieves after 1 and 2 hours because it's humoral in nature. Vomiting, if it's associated with nausea, it usually has a inflammatory. But if it's not associated with nausea, it's usually non-inflammatory. Vomiting, is important to check for the color of the vomiting. Is it white or green or dirty with feces or coffee ground? If it's white, usually there is no obstruction, but if it's green, usually that it's from the duodenum. Dirty with feces or something, it might be an intestinal obstruction. If you have a patient with cholecystitis with severe vomiting, but white, not green, what does it indicate? This indicates that there is obstruction in the biliary system, because it should be green. The time between vomiting and pain is very important. How is that? Because if a patient with intestinal obstruction has a pain now, but he only vomits after 3 to 4 hours, okay, and the contents are feces, this indicates a lower intestinal obstruction. But if the pain starts now and after 14 minutes the pain starts, this means that the obstruction is high up in the GI. Yes, this is an important question. What's the difference between radiation and referred pain? Radiation is a pain which is the extension. Radiation is an extension of the pain, okay? It's an extension of the pain distal to the side from its felt, okay, with persistence of the initial source. But the referred pain is feeling the pain in a site distant from its origin. So in radiation you have pain in your in referred pain, as in cholecystitis, the origin is the gallbladder, but the pain is felt on the shoulder. This is referred. But radiation, the pain is felt in other place with persistence of the initial pain.